In North America, and good afternoon to our colleagues in Ireland and throughout Europe. Welcome to our first Forensic Psychiatry Continuing Professional Development webinar series. This series is designed for an international audience, and this is a place where we will have an opportunity to discuss a host of different topics within forensic psychiatry. Our goal with the series is really to provide salient and timely information on issues that are both of interest and importance to our field, that crosses borders and that uses expert panelists to lead the discussions. So I'll start off with some introductions. I'm Sumita Chatterjee, and I'll be the chair for today's session. I'm coming to you from Toronto, Canada, where I'm a forensic psychiatrist and the medical head of inpatient and outpatient forensic services at the Centre for Addiction and Mental Health. I'm also the program director for the Forensic Psychiatry Subspecialty Residency Program at the University of Toronto. In our audience today, we have members of the forensic psychiatry community from Canada, Ireland, and throughout Europe. It looks like we have over 43 participants at the moment. And I'll just ask Milena to mute all of the participants except for the speakers here today during the discussion portion. So for today's event, now we recognize that there are a number of salient and important issues that we could discuss. But for today, we will be talking about the issue that has been on everyone's mind for the last several months, the COVID-19 pandemic. We've all been witness to how the world has been profoundly impacted by COVID-19 in countless ways. Now, for us in forensic psychiatry, my apologies, there's a code white in the background. For us in forensic psychiatry, today is a chance for us to speak about the observations and lessons of two centers in two different countries in addressing and managing this pandemic within their forensic psychiatric services. The format for today is to have two discussions, each 40 minutes in length, led by Dr. Sandy Simpson and Professor Harry Kennedy, who will be no stranger to many of you, but whom I will introduce more formally in a moment. Each of their 20-minute discussions will be followed by discussants' comments. However, we do want this to be an interactive session, so we encourage your comments and questions. Please do post them in the chat box. I'll be tracking the chat box and posing your questions and comments to the speakers in the last 10 minutes of each presentation. So on that note, let's get started. Our first topic is the anatomy of an outbreak. Our presenter, Dr. Sandy Simpson, is Chief of Forensic Psychiatry and Clinician Scientist at the Centre for Addiction and Mental Health. He is an Associate Professor in the Division of Forensic Psychiatry at the University of Toronto. He is involved with multiple international forensic organizations. He's a member of the editorial boards of Criminal Behavior and Mental Health, the Canadian Journal of Psychiatry, Frontiers in Psychiatry, and the International Journal of Risk and Recovery. Dr. Simpson has over 100 refereed papers, as well as book chapters and monographs. The discussant for his presentation is Dr. Mary Davoren, who will be the discussant, and she is a forensic psychiatrist at Trinity College, Dublin. You can see her sitting behind Professor Kennedy. So Dr. Simpson, please take it away.
Thank you very much, Sumita, and can I share, thank you for your words of welcome to everybody. It's super to see everybody joining from across Canada, across Europe, old friends who we're not meeting in Krakow this year, but having some way to link and discuss what are remarkably important events in our discipline is part of the purpose of this webinar series. So welcome, please join in with the discussion, please share your thoughts and experience, and I hope in time we'll, as this webinar unfolds, we can bring in new topics and presenters from outside of Dublin and Toronto as well. My why did we commence this? Well, If I share my screen, I trust you can see that. The issue from our end, and the reason why it's called anatomy of an outbreak, is because that's what we have had here in Toronto. We were rapidly in the situation of having to respond to an outbreak in our facilities, and I want to present that to you, talk you through that context, talk you through the principles of management that we were forced to employ, because this has not been talked about at all in the world literature to date, and yet it's the reality that we all fear or have had to manage within our facilities. So the objectives of my presentation will be to describe the setting and the community context of COVID in Toronto, to describe the planning that we performed to respond to that risk, and then the outbreaks that occurred in 2 of our units and how we managed those. The acknowledgement of my colleagues there is are listed because this is a paper that has been accepted for publication in the Canadian Journal of Psychiatry, and I hope will be out soon. If you want a preprint of it, please drop us an email, and I'm happy to share it with you. So the Centre of Addiction and Mental Health is a 550-bed mental health facility in downtown Toronto. It's integrated closely with the local community. We have limited grounds of our own, so patients are into the coffee shops and the drugstores and the local community, 50 yards from the front door of the forensic facilities. We're about 30% of the hospital, forensic that is, and the forensic program here is about 30% of all of Ontario's forensic services. CAMH is smoke-free and tobacco-free, with the dynamics that emerge from that. The other local information that's important for you to understand is that SARS of 2003 had one of its epicenters here in Toronto. So pandemic planning became a core organizational activity for public sector agencies in Toronto and Ontario. Our service particularly is primarily in 2 5-story towers. These are buildings that date from the 1960s with what was the common brutalist architecture of that time. There's very limited space for staff and patients. We have 185 medium and minimum secure beds here. Maximum security is provided at Waypoint, just north of Toronto. We're both mixed gender and single gender settings. The medium secure units are of 28 beds. That's a mixed gender acute ward. Yes, you heard right. Mixed gender, medium secure, forensic acute admitting ward. There's a story behind that we won't have time for the day. 2 20-bedded medium units and 1 unit of 16 beds split into 2. On the minimum side, we had 2 30-bed minimum secure units, 1 22-bed and 1 16-bedded unit. Staffing ratios vary between 1 patient to 1.1 staff or 1 patient to 2.3 staff per 24 hours. So they're heavily staffed in those across the 24-hour period. We've had a history of having difficulty managing viral respiratory or GI outbreaks, particularly in the large minimum secure units in the past. So we knew infection control issues were going to be a significant problem should we get outbreaks during the COVID period, particularly in those units. The patient profile is as you'd expect. Mean age of about 40, 90% with a primary psychotic illness, the remaining 10% with a range of neuropsychiatric disorders, 85% not criminally responsible, 10% unfit, and the remainder are small numbers of restoration of competence and civil patients with treatment-resistant violence. We have about 2 to 4 admissions per week to our beds from community and detention centers. So Ontario generally, 14.5 million people in the province with a heavy concentration in southern and particularly southwestern Ontario, where we are placed. 4 cases occurred in January, the next in February. Those were all likely travel related, with single figure cases emerging in March until 11th of March, when when we began to double every 3 days and the community spread of the epidemic became recognized. Major tragedies unfolded in long-term care facilities for the elderly. Indeed, the Army has been called in to manage some care of the elderly facilities in Ontario. Across Canada, about 75% of all COVID deaths have occurred in long-term care facilities for the elderly. In Ontario, our numbers peaked at 606 per day on April the 20th, with a gradual reduction since then, but we have plateaued for the last month. So our R value remains at about 1, averaging around about 350 cases, new cases per day in Ontario now. But graphically, it looks like this. As you can see, starting to rise in early March and peaking then in mid-April, falling, but we have remained through May and currently at around about this 300 to 350 level, and do not see a reduction beyond that, which is causing considerable concern. The green arrow emphasizes the point at which the first staff case occurred within the forensic service here. And so and this was likely travel related by staff, which was where the epidemic was getting fueled by in mid to late March in Canada. So our hospital-wide COVID pandemic preparations began in February. Infection control machinery was slowly getting geared up with the messages around hand washing, physical distancing, and disinfection. Community spread in mid-March hastened that process, and you can see the rate at which we started to make decisions in relation to the curve I've already shown you. A working party to establish isolation and admission cohorting procedures began in early mid-March, and forensic was included in that. Screening of all staff and visitors commenced in mid-March. Limitation of group activities, outpatient visits, then coming in later March as hospital-wide policies, which forensic followed, and a cessation of many community clinics and elective processes occurred in the last week of March. Forensic specifically, we ceased all unaccompanied ground and community passes by March the 23rd. Again, for context, we have very limited spaces for outdoor access and very limited hospital-related rehabilitation abilities because of the structure of our facilities and patients needing to go to rehabilitative activities, particularly later in their care pathways. There was a lot of issues with patient congregation in a nearby park, sharing cigarettes and cigarette lighters, remembering our units are tobacco-free, that we saw as a major risk of community spread emerging and of bringing the virus into our inpatient units. Visitor and student placement cessation mirrored the rest of the hospital, as did the curtailment of group activities. And then we had major changes to medical staff deployment. Every one of our units has 2 psychiatrists working on it. So we implemented a week-by-week basis where one psychiatrist covered the inpatients, the other worked virtually 1 week, swapping for the next. We also made sure that psychiatrists were not working across our 2 towers, and we limited working across multiple facilities, courts, prisons, community inpatient units in late March. Virtual care was rolled out very rapidly. We used WebEx as the platform. Team meetings, morning huddles, and patient reviews were within 1 week all shifted, where at all possible, onto virtual platforms. Personal protective equipment was rolled out, with all staff being required to wear masks in all interactions with each other and with patients from the 27th of March. One of the key points in our response was the implementation of an isolation unit. WHO, CDC, and the European CDC all recommend isolation units, but there's very little description of what these actually mean in a mental health facility. So our working group, you'll recall, was established in mid-March, and our 6-bedded isolation unit within a medium secure unit opened on the 10th of April. Careful protocols for referral care, medical care algorithms, and training staff and the full use of PPE were employed. 4 bedrooms with 2 rooms that could be used for seclusion or as bedrooms were available. We did not offer extra medical care such as IV or external oxygen. It was simply supportive care with hospital transfer if oxygen saturation levels fell below 93%. We gave out tablets to the patients for interviews, video calls, connection with family, and heavily loaded up with Netflix for their entertainment. So how did the outbreak occur and how did we manage it across the facility? Our first forensic case was of a staff member who on March 23rd reported symptoms while on a shift in a medium secure unit. She felt unwell, went home, and her positive COVID result came through on March the 26th. 2 physicians and 10 staff from that unit were sent off for home isolation for 2 weeks, and 3 patients were placed on droplet and contact precautions. None of these 15 people became COVID positive, but this was before everybody was wearing masks, and it became very clear that to support the ongoing integrity of our teams, we had to be able to protect staff because we couldn't afford this rate of staff going off on home isolation if we got further positive cases. The first outbreak occurred 2 days later in the 16-bed medium secure unit on the ground floor of the tower I'm in at the moment. 3 patients in one wing reported symptoms, and 4 staff also reported symptoms in those days. The outbreak was declared after positive swabs were returned on March the 27th, and we had further cases on that floor on March 31, April 1st and 7th, when we had 2 people becoming positive, on the 8th and on the 10th. And on the 10th, you'll note as a result of swabbing for asymptomatic cases. I'll discuss this further, but one of the crucial things, and it took some advocacy for us to be able to do so, because we were ahead of the asymptomatic swabbing curve at that point. We swabbed everybody on this unit, that's all staff, all patients, and on the other outbreak unit on April the 10th, and that became very important to manage the outbreak. So in all, 9 of the 16 patients became positive on that unit. I note that all bar 1 of these cases became positive before we were able to establish the isolation unit. Full PPE was employed, droplet and contact precautions for all patients, and tragically, 1 of those initial 3 patients deteriorated quite dramatically on day 8 of her illness. She transferred to a major hospital ICU, but died on April the 22nd after 3 weeks of intensive intervention. She had no pre-morbid medical conditions other than schizophrenia. She had extracorporeal oxygen support for 2 weeks. They did everything that could be done, but she tragically died. The outbreak was declared over on May the 5th, 42 days after the first symptomatic cases. So the second outbreak occurred on the 28-bed minimum medium secure acute unit, also in Tower 3. The first case occurred a little later on March the 30th, with further cases on April the 5th. We detected 1 asymptomatic case on April the 10th, but further cases occurred on April the 17th and 19th. Interestingly, neither of those people were COVID positive on the asymptomatic screen. So we had 5 patients in total from this 28-bed unit. These new cases, however, came at once we'd established the isolation unit. So all 5 of these cases, as they became positive, transferred to the isolation unit on diagnosis. None of these patients required transfer to a general hospital or recovered unremarkably, and there were no staff positive from that unit. This outbreak was declared over on May 7, 42 days in duration also. What this did do was shut down our ability to admit anybody. It shut down all our forensic acute admission capability, which caused, as you can imagine, some consternation for the courts, the prisons, and other parts of the forensic system. Testing for asymptomatic cases it was very important, as I've noted. Asymptomatic people are probably the Achilles heel of outbreak management, and indeed the COVID pandemic management internationally, as has increasingly become recognized in recent weeks, but wasn't clear when at the beginning phases of this process. It was difficult to get accepted how important this was in early April, though by late April and May, that was then became usual practice. Eventually, we got this done on April the 8th or 9th, and 2 positive cases, 2 positive patients and 1 positive staff member were found as a result of this. It's very important to treat units as an ecosystem of all staff and all patients needing to be tested if we are to effectively manage outbreaks and manage the risk of outbreaks. So the things that we learned that were important principles, firstly, that because we curtailed community passes significantly before there was widespread community spread in the shelter system and amongst persons with mental illness in our community, we, the staff, were the most likely source to bring the virus into our facilities. It was we who had traveled, it was we who had been in more high-risk areas, it was we who were likely to bring the virus in, and indeed that was the case. Our outbreaks were in the medium secure areas where people did not have off-ward passes. It was staff that were responsible for the introduction of the virus. Attendance to the basics of infection control and nosocomial spread was essential, and we didn't have a good track record in that area in a mental health hospital, although that has over the last 2 months improved very considerably. We have to protect our staff teams by reducing flow, by virtual care, by new forms of deployment, so that we can, an outbreak in particular areas does not downgrade our functionality overall, and we've effectively managed that here. In total, because of travel and outbreak exposure, we had 7 psychiatrists in all on home isolation across various phases of the outbreak. The ability to detect and rapidly isolate is crucial. So that involves, especially in our facilities, with our patients with very difficult compliance with droplet and contact precautions. So swabbing for asymptomatic persons, staff and patients is crucial. It is important, I think, from a thematic perspective, to make it clear that our facilities are like congregate living settings, like long-term care homes, like prisons, secure hospitals rank beside them. We share much in common, and we should be treated the same way by public health authorities, with rapid thorough testing at the first sign of infection, and with all those screening processes in place to protect our facilities. Isolation capacity is very important. Asymptomatic testing, very important. Upskilling of staff and patients in this is vital. The patients, 70% of them get it, were frightened of the virus as well, didn't want a lot of people coming onto the units, and have been remarkably acceptant of the curtailment of their liberties as an issue of public health rather than as public safety that we normally use our control mechanisms for. Intriguingly, this week, one of those 30-bed medium secure units had a staff member become symptomatic we were able to, within one day, get all 30 patients swabbed, and everybody agreed to do so, and all staff were swabbed as well, all are negative, and with no further issues emerging. So the rapidity with which we were able to do that, the compliance and acceptance of it was dramatically different to how it was in March and early April when the outbreaks occurred, which I think is a recognition of the cultural change and responsiveness that's occurred over these weeks. So I will stop sharing my screen at that point and look forward very much to your reflections, comments, and feedback.
Thank you so much, Sandy. Is everybody able to hear me? Okay, that was a really interesting talk, and I really just want to pick up on a few pieces. I think the first point that you've made is that actually in forensic settings, we run on very high capacity in terms of we are often at 100% bed occupancy or very close to it because there's often a lack of forensic beds in systems. This has really reduced our ability in terms of having isolation beds within our hospital. I know that some of the high secure units in England run with the idea of decant wards. So they have wards that are ready to go for emergencies such as major incidents, etc., when you have to clear a ward. And I suppose I was just wondering, in light of the coronavirus outbreak, do you think people need to think about having decant beds or decant wards in secure services from the infectious disease perspective?
Yes, one of the major difficulties with our management is the poor quality of our antiquated nature of our facilities. So I think if we were in a setting where we had seclusion suites or high-risk areas where we could isolate people more easily, where they could not just be stuck in their own room, but have their own toilet facilities and so on within a negative profession context, and that would have mitigated some of our risk. Certainly the major outbreak on the 16-bedded unit was considerably hampered by the very cramped nature of it, the lack of individual bathrooms, and the difficulty that that particular patient group have with complying with droplet and contact precautions. So we need facilities that recognize that those are risks that the patient group must manage, and that we must be thoughtful about how we design our facilities with that risk in mind.
Thank you. The next question I was going to ask was something about admissions, and we recognize that staff members coming in and out of secure units are probably the most likely people, and certainly they were in your case, to bring in the infection just because they're going to supermarkets and going home to families, etc. Did you put a hold on admissions from prisons when the outbreak happened, or did you continue admitting as usual? Or did you isolate new admissions when they came in from prison settings, etc.? Because there was a lot of concern here in Ireland that perhaps there might be an outbreak in a prison and we might admit someone and the prison realised perhaps a week or two later that they had an outbreak, given the delay between symptom onset for the COVID. Or did you just keep admitting as usual?
During the early phases, we were continuing to admit. And indeed, the virus wasn't at that stage in the prisons as far as we knew. And there were concerns about the prisons, but undoubtedly, as you could see from the curve of spread, it was likely to be much more widespread than we thought. We didn't have to worry about admissions because the outbreaks were in the units that we admit to, and we couldn't admit anyone because of public health rules. So we had 42 days where we didn't have to worry about admissions because we couldn't. Since we've reopened, we've changed, we've had to establish a cohorting unit for all admissions coming in. So we have protocols developed with the admitting agencies, primarily the detention centers, to try and and the detention centers are now well geared up with cohorting, screening and isolation in them as well. So everybody in prison is getting swabbed and before coming to hospital. Well, that's the good story. The bad story is the people who get admitted to hospital are the sickest and they're the least cooperative and they're refusing to be swabbed. So we're needing to, we have now developed, and what indeed was that first unit that where we had 2 wings, where the outbreak occurred, we have turned half of that area into the cohorting unit for all new admissions. So people stay there for 2 weeks if they're refusing to be swabbed, or 7 days with a swab on day 5. If that's negative, then they can move to their mainstream unit. So we established isolation first and cohorting second.
Okay, thank you. I just have one very quick final question because I think we're moving on in terms of time. Here in Dundrum, we moved to a situation where we no longer have MDT members on the ward round. It's just a nurse and doctor, and we have a more of a distance approach to ward rounds. I think a lot of people are now implementing distance medicine. I suppose I just wonder, is the actual day of the multidisciplinary team sitting around in a circle with the patient in the room, is that over? Is it a thing of the past?
It is here, and I think we should devote one of these symposia to virtual care and its implications. Whether it will be long-term, I think for many of our community patients, for whom it can take an hour and a half or 2 hours to get here for their outpatient appointments, for those people, it may well be. But the large groups, the transferring of that onto WebEx has gone remarkably smoothly. But how long will that be? Maybe Harry will address that, or your comments. Be interesting to hear from others as to how they feel about it.
Okay, thank you so much. I think that's all my questions. Shall I hand you back to Sumita?
Thank you, Sandy. Thank you, Mary. I'm just looking at the chat box. We don't have any questions or comments now, but perhaps I'll give everyone a moment to collect your thoughts and make any comments or pose any questions you would like. I'm thinking about calling Gary out on some vigorous head shaking a moment ago.
No, I think, thanks, Sumita. I think there are multiple reasons for my head shaking and nothing to do with this here. Certainly with respect to team meetings, we quickly implemented video team meetings. So we probably have about 8 people in a room, and people WebEx into the meeting from their offices. But we are looking at ways of, so one of the downsides with that we've discovered is we used to have several physicians and residents in our team meetings. And as a result, the patients were reviewed, I guess, in a sort of almost a 360. And with one physician at a time, we've run into some difficulties where you don't have the same reflection on managing patients that we used to have when we had sort of a combined team meeting. So we are trying to now bring in all the physicians for all of the patients by video. So we've figured that was one of the major downsides of having only one physician at a time videoing in. And that sort of more systemic review of the case and the complexities of forensic cases we lost. But still, we're trying to accommodate. But I think, we have a slightly more modern plant than you guys, so we've got more space to put people in a room than perhaps you guys do.
Sandy, and correct me if I'm wrong, but I feel like those are very similar discussions that we're having here at CAMH in terms of the use of virtual reality and the balance of pros and cons, what you gain, but what are also the sacrifices, and how to mitigate those sacrifices in the longer term to create a sustainable model that manages the months ahead of us of the pandemic.
Yes, I think as an emergency change within relationships which were well established therapeutically with people, being able to tick that over using virtual formats, and I'm thinking both team relationships and processes and relationships with patients, that's worked okay. But with the week on, week virtual processes that we've had, there's some sense that for some patients is, okay, well, we'll see the doc weekly, virtually, but the proper decisions will occur when the person's there face to face. So I'm not sure if we know what the experience or the efficacy of virtual care will be in the medium term. And that I think will be we've got an evaluation plan for that. I think there are a lot of really interesting questions around how much forensic care, risk assessment, risk management, recovery-based work can be done virtually. What are the gains and losses of that? I think will be a fascinating thing for us to explore.
Any other comments or questions from the audience before we move on to our next topic?
Samita. Sorry, I typed one out, but I don't know if you saw it.
Oh, here we go. Just saw it. Go ahead.
Paul, can you just introduce yourself to people who don't know you?
I'm Paul Benassi. I'm one of the psychiatrists here at CAMH, and also involved in doing quality improvement in our division. I just think one question I think for anyone is that I saw come out in this pandemic is the challenge of balancing how we restrict our patients' privileges in the support of public health, and how to navigate what's appropriate and necessary, and how far we would go in that domain. I think that is a challenge. I think recently we had a thing on the news where it was a beautiful summer day and one of our parks was completely full of people not following any of the public guidelines, not our patients, because they're not going out, and having that conversation with my patients later about how much kind of in a paternalistic way we're using our powers for public health concerns, but how do you strike the balance and around that, since we usually restrict privileges based on risk and more so risk to the public. And so there is a risk to the public in this area, but then how much do we use those powers to enforce public health concerns? I think was an interesting dilemma that came up.
So one of Paul. So one of the things that we were struggling with was exactly that. But our analogy for our COVID outbreaks in Ontario is that we almost had two outbreaks. One is we had an outbreak in the long-term care facilities, and the other was the rest of the population. And then we began to see our forensic program as almost like a stationary cruise ship, or essentially a long-term care facility. So I'd say until we overreacted, but we locked down way more than we perhaps would have if we were a more open program. So we probably treated our program, as I said, long-term care facility, and you're quite right. So we restricted a lot of people. Our problem right now is, what do we do now? It's not how we got here, it's how do we get out of this? And our hospital is talking about getting rid of the COVID warm units, the spaces that we put aside for COVID. We haven't had any COVID cases in the mental health program, in the forensic program here, but we will as we open. And it's the opening that we're struggling with. I think for us, the difficulties are coming as opposed to that we've had as we give people back their freedoms. And that's going to be, I think, a challenge. I mean, the only hope we have is that the mutation that the virus is going through, that it is, as some people are saying in science, that it might be weakening. But I mean, that's a hope as opposed to a reality.
Hi, it's Elizabeth here. I would agree with Gary's comments about the struggle in reopening, and we're facing that right now at Ontario Shores. We're trying to implement some new admission guidelines so that we can move people through because of the same concerns about restrictions and the limited space we have to isolate individuals. And so I think this is a bigger conversation moving forward about how we allow people back into our system, how we transition them through safely, with also balancing what's appropriate and necessary. It is a real challenge with limited space, because now we have all these beds that we're saving for isolation, but yet we have to move throughput. So where do we move those people to once we determine that they're safe to reintegrate? We don't have, physical space to do it with new beds. So it's a real challenge how to manage that confined space.
Thanks, Elizabeth, and thanks, Gary, for your comments. There's another comment here, just says from Forensics Department that a similar issue, that what is a sustainable model moving forward, for example, with alternating week in hospital and week out hospital. And I wonder, perhaps, Harry, that's an issue that you'll be addressing, as well as what is the pathway forward for forensic psychiatry. So I think this is probably a good bridge into our next topic. Professor Harry Kennedy will be talking about how will COVID-19 change forensic psychiatry. So Professor Harry Kennedy, if you'll give me a moment to introduce you. I know you're very humble and this will probably embarrass you, but I'm going to go forth. Professor Harry Kennedy is a consultant forensic psychiatrist and executive clinical director at the National Forensic Mental Health Service Central Mental Hospital in Dublin, clinical professor of forensic psychiatry at Trinity College, Dublin, and an honorary professor of forensic psychiatry at the University of Aarhus. He's formerly the clinical director of North London Forensic Service in the UK. He is also an expert advisor to the Council of Europe Committee for the Prevention of Torture. Professor Kennedy also teaches forensic psychiatry and publishes research on the epidemiology of homicide and suicide, therapeutically safe and secure pathways involving the Dundrum, neuroscience and violence, mental health law, and human rights. Dr. Trina Wilkie will be the discussant for this session. Dr. Wilkie is the Associate Physician-in-Chief at the Center for Addiction and Mental Health in Toronto. She is also the Associate Chief of the Forensic Division at the Center for Addiction and Mental Health. So welcome to you both.
Thank you very much, Smita. First of all, can I say how delighted we are that this has got off the ground. From a late night set of emails between Sandy and myself, it's terrific to see the interest. Of course, this has affected us all right across Europe, right across North America, and it's terrific to see people from a wide range of places here, because we're a very small peer group. We don't often get to meet. More than usually, international meetings are important to us, and this is probably the only type of international meeting we're going to have for some time to come, and that's partly what I'm going to address. So let me first of all test my technology and try to share my slides. There we are. Right, first piece of good news is that has worked. So next, that would be good, would be if I could move my slides. Ah, there we are. So where were we in the late winter of this year? So in January or February, we were due to move from this 1850s building where we are at this minute into a brand new purpose-built, state-of-the-art designed forensic hospital. We were going from 102 beds that we have at the moment to 170 beds. We will have specialist pathways for men with mental illness, for women, for people with mental health and intellectual and developmental disorders, and for children. All of these providing much needed services that we currently lack. Ireland has fewer forensic beds per 100,000 than most other European or North American services. We have 2 forensic secure beds per 100,000. The norm in the UK would be about 7.5 to 10. Right across Europe, it's mostly about 10 beds per 100,000. Australia and Canada, somewhere in the middle there.
Harry, sorry to interrupt. We're experiencing a little bit of static, audio static. I don't know if there's a way to adjust the microphone.
Okay, I'm not hearing that here, so I don't know what that is. The microphone is the one that we have here. I wonder where that's coming from. Can people hear me?
You're clear now. Some people are saying no static. Maybe it's my computer. Okay, my apologies.
Okay. So, we were all poised and due to make this move in September, when, as Sandy has described, in beginning of, from about February onwards, we were hearing of serious problems, particularly in Italy and in Spain. And then, as we began to think this is coming our way, things got going towards the middle of March. So what I'm going to do is to take us quickly through the headings, while not going into as much detail as Sandy has described, because to a remarkable extent, we have done very similar things. And probably the differences will be more in the dates than the actual actions. So first, can I just talk about emergency guidelines? And this, of course, is the Diary of a Plague Doctor. There's nothing new about any of this. And first into the field was the Council of Europe, which is the parent body for the European Convention on Human Rights. It's not the same as the European Union. It's big Europe. It has about between 40 and 50 member states, going as far as Ukraine in the east and back towards Iceland in the other direction. It issued a one-page set of ethical guidelines, which are tremendously helpful. They restate the principles that we would normally be applying to people in custody, statement of principles relating to the treatment of persons deprived of their liberty in the context of the coronavirus disease pandemic. And these are principles that any of us would recognize, really, translated and applied. Similarly, our own government, Department of Health, issued guidelines which very much echoed the Council of Europe guidelines. Around most European states, this is what happens. We get a central view, often nothing like so quickly or nimbly as this, and all the various member states adapt, but keep the core substance very much in place. So this is about minimizing harm, proportionality, solidarity, fairness, the duty to provide care on an equitable footing for people detained, just as they would get if they were in the community. Reciprocity, which is something we hadn't come across before, but points out that frontline workers who put themselves at risk have a reciprocal right to appropriate treatment when we fall ill. That's a really interesting point, which I've never heard articulated except in this recent context. And of course, privacy. Those who fall ill have a right to their privacy. And this is particularly true amongst a bunch of clinicians. Here in Ireland, our National Public Health Emergency Team, made up of the Chief Medical Officer, the Chief Clinical Officer, who are both in that picture, who are normally completely anonymous people who do not participate in the media, have become overnight press conference stars. And it's an interesting test of a culture that in what we think of as the island of saints and scholars, except that we're not so saintly anymore, the government and the public recognized and accepted scientific advice with absolutely no debate. There has not been dissent, really, certainly up to this point, about any of the measures introduced. And that's really quite interesting. It's not something one could have confidently predicted. So what have we been doing in the light of these guidelines and national guidance, which applies to everything? How does this apply in our setting? Well, we had very clear guidelines, first of all, from the National Public Health Emergency Team. This will be familiar to all of you, but this sort of thing became part of a snowstorm of guidance, which came out every day and was revised every other day. But the theme that we saw here was the remedicalization of our practice to an extraordinary extent. So things like, how will a nurse on a ward notify the duty doctor about the nature of a physical health problem. And Aidan Rorty, who asked a question as well just now, who has just finished his higher training as a general practitioner before seeing the light and coming into psychiatry, was able to help us with these things, standardized ways of reporting on physical illness, which we needed to relearn. It was a huge help. Similarly, these scorecards, the National Early Warning System scoring key, which my peers who are A&E consultants, emergency department consultants, physicians were completely familiar with, were fascinated to see these translated into our setting, and indeed we were as well. These sorts of systematized assisted decision-making, of course, are very familiar to forensic psychiatrists with structured professional judgment, so it wasn't too difficult for us to adapt to this at all. Early on, I began keeping a diary, and I initially thought that for this talk, I'd show you the whole diary, and I realized that I could fill an entire screen and much more with each week. So for the time being, this is just a summary of essentially how busy it was. We began to formulate what we were doing in terms of therapeutic security, and we talked about procedural, relational, and physical security. But of course, how to communicate became a key issue, and legal adaptations. And again, our Parliament rushed emergency legislation through, essentially to make it legally acceptable to do statutory assessments using telemedicine, which would otherwise have fallen foul of definitions. And they made a very small, very partial concession in that area. Here's the rest of the weeks. So crucially, daily teleconferences, indeed twice, 3 times daily teleconferences at different levels. A national one for clinical directors, 2 in-house here, which we were able to do, which are universally recognized to be of such benefit that we won't be giving them up. The ability to communicate clearly and make decisions which everybody has buy-in to has never been as easy. The National Forensic Mental Health Service here is a fully integrated pathway. So we do the prison in-reach psychiatry, we do the secure hospital care and treatment, and we do the community aftercare for those who are conditionally discharged. Our prison in-reach is a very, very large part of what we do, and we don't see it as distinct from our hospital work. Most of us who have inpatient work also will have clinics in prisons, although some of us, currently 4 consultants, are full-time in the prison, the various prisons around the country. Now, because of the necessity to avoid cross-transmission, we immediately had barriers which we normally go out of our way to avoid. Our model of care is all about fully integrated care pathways. Now, those means of communication become infinitely more important because colleagues who we would normally have lunch with now can't come into the hospital for fear of crossing between a prison and a hospital, or even between one prison and another. Very quickly, the commonality that we had, which Gary Shainlitz mentioned just then, the commonality that we have with, for instance, nursing homes and obviously prisons, closed environments. The first analogy I remember hearing was the difficulty people were having on cruise ships. Some of you will remember back in March, there were cruise ships that weren't allowed to dock because they had outbreaks. They were going round and round in circles in the Mediterranean and in the Caribbean, trying to find somewhere they could come ashore. We are perhaps rather like a cruise ship, but without the facilities. Similarly, people became aware that vulnerable populations included the homeless, those with serious substance misuse problems, as well as the elderly and infirm, because our patients age prematurely. And so the endemics of substance misuse, of homelessness and vulnerability, the stage army that cycles between the prisons, the streets, the addiction services and the psychiatric hospitals, really became a very important focus. And although the death rate from SARS, which is one of the more reliable statistics, has been middling in Ireland, it's not been very low, it's not been very high, but about half of our death rate has been in homes for the elderly. So this became very conscious, very much in the front of our minds. And we were particularly anxious, of course, about our prison populations. And a lot of those weeks of urgent planning, preparation, and change focused as much on our prison in-reach services as on the hospital. We've mentioned, and I'm not going to go into it again, about decant capacity and the need for isolation pods or cohorting pods, as we call them. Normally, this hospital runs at 100% occupancy all the time. We just don't have empty beds. Therefore, this was a major challenge for us. And so, with the help of the Department of Justice, the Department of Health, and the Mental Health Commission, the registration body, we opened at breakneck speed one of the buildings, which was near completion, one of the ones that was actually completed, and moved our pre-discharge ward patients lock, stock, and barrel over there so as to generate a decant space here, awaiting the outbreak that we all know has to come. But here's the thing. By the time we had achieved that, we'd already set up systems for screening staff coming in and out. We had stopped all physical visiting, transferring that to Skype. We'd stopped all leave outside the hospital. And as of this minute, we haven't had a patient who has tested positive. We've had lots of patients who've had symptoms and had to be isolated and tested. In the early months, our testing here was very different to your experience. It would take us 4 or 5 days to get a test done, and the results were coming back on days 15, 16, 17, by which time really they weren't very useful to us. That has improved, but only in the last couple of weeks. We're now getting results back within about, between testing and results, it takes about 48 hours at this point. So we have managed, essentially, assuming that everybody with symptoms is a case and managing accordingly by isolating and cohorting. Where are we going next? I'm showing a picture of Neil Ferguson, who's one of the leading infectious disease epidemiologists who spoke truth to power. He was the lead in the UK's scientific advisory group for emergencies, SAGE. And early on, he drew attention, this is from about the 16th of March, this paper, which was published to the web prior to refereeing. Rapid communication has suddenly become a thing. You don't wait for something to appear now in the Lancet. And amongst the alarming things this shows is the exponential relationship between death, the infection fatality ratio, and age. So for all the clinical directors tuning in at the moment, folks, stay well. These were early on not just the interventions available at a societal level, but estimates of the effects they would have on the population rates. And it's from this that we got the idea about flattening the curve very early on. One of the things I want to say now is that in the earliest of these papers, the epidemiologists were saying that as soon as you let up, there will be a second wave. And if you look at the dates, they were optimistically thinking that that we'd be easing off in July, and the second wave would be coming in October. Now, obviously, political pressure is easing off a little bit earlier than that. So the question is, when will the second wave come? Because it seems almost inevitable that it will come. Here's a second piece from Ferguson's group showing what he thinks will happen. That one of the options is to manage this in terms of ventilator capacity. So you clamp down, you lock down for 3 months, you ease up for 1 month. When the numbers presenting needing ventilation go up, you clamp down again. And this may be how it goes well into the end of next year, or until there's an effective vaccine and it has been delivered to the point where you have herd immunity, 60 to 70% vaccinated. Interestingly, he was not the only writer. This is the second view about how many days from the beginning you'll get the second peak. So currently we're about 100 days in, and the prediction is there'll be another one in about another 100 days. One of the joys of this rapid publication thing is that scientists everywhere have dropped what they were doing and concentrated on COVID. Carl Friston is probably the most well-known cutting-edge neuroscientist out there, and not somebody you normally think of as a contributor to psychiatric literature, although he is in fact a psychiatrist by trade. He's now based in Queen Square, and he is a member of Independent SAGE, which, given what has since happened to Ferguson, is a very valuable thing. He's quite an outspoken character. He smokes from conviction, he says, and he has largely replicated those models while at the same time improving on them based on neural circuitry and a whole theory of causation, which is fascinating. The reason I mention this is because mathematical modeling of things like risk, things like length of stay, is something that we think of as core to forensic psychiatry. I have to say, where the best technology is now is where that will be for us, I hope, in 5 years' time, maybe earlier. But there is so much that we can learn from Friston's group about managing risk. Here's an alternative view, because science is never cut and dried. So I think most people know that Anders Tegnell, the lead epidemiologist for Sweden, guided in a very different direction and has had the scientific objectivity and grace to now say that perhaps he mightn't have got it completely right. But nobody's going to get it completely right. And another one, certainly people on this side of the Atlantic will be familiar with Ben Goldacre, who started off running an organization called Quackbusters and has very pointed things to say about vaccine deniers. But he has managed to demonstrate the power of very big data. And again, I have no doubt that that's where all of this will be going very quickly. I know that Gary Shamovitz has a particular interest in that. It's interesting to think where this is really going to take us next, never where you expected. Telemedicine and court video links, overnight. This has transformed what we all do. Interestingly, we all tell each other this has transformed things overnight. We have struggled because a lot of the devices that many of our colleagues are using didn't have Windows 10, so therefore they didn't work with Microsoft Teams or any of the other platforms that we tried to get going. Now, 3 months in, we're just about there. What has always worked extremely well is the old-fashioned landline telephone, which is still actually very, very good. Interestingly, from a forensic point of view, at a very early stage, I had to go off and talk to the state claims agency, our state insurers, about the extent to which we would all be covered for using this, and generated some guidelines with them, which again are very simple and very, very supportive. Essentially, anything that one is doing that is reasonable is supported, but it must be reasonable. What about patient resilience and patient risk? For example, telling all the patients that a member of staff did a shift on their ward who has now tested positive is a major stress. And without going into too much individual detail, I know that on Dr. Davoren's ward, this became a very lively issue, particularly with patients whose delusions were seriously stressed by the thought that they might be at risk of imminent death. What about this? What can we do to support our patients to improve resilience? Well, first of all, a key message for us is refocusing on hard outcomes. We have spent perhaps 30 years thinking about recovery. But what we've missed is something that Lisbeth Erskov Sorensen, if she's online, pointed out recently from the Danish whole population databases, which is that the mortality ratios, standardized mortality ratios in schizophrenia, have been getting gradually, steadily worse year on year for the last 20 years, at a time when they've been getting gradually, steadily better from all causes mortality in the general population. Cancer, respiratory disease, cardiac disease have all incrementally grown better and better and better. Things are getting worse in schizophrenia, and for forensic patients, in Elizabeth Erskough's paper, worse again. So perhaps it's time we refocused on medical goals. We need to be co-producing with our patients as partners the knowledge about hand hygiene, hygiene more generally, social distancing initiatives that work for people, particularly people who are in hospital and transitioning to the community. Good ideas are never good enough. Psychiatry is plagued by ideologically sound ideas which either don't work or make things worse. Even in recent times, we've seen speculation that BCG might work. That's still live, but there's a wonderful paper from Israel showing, I think, categorically that it doesn't. Vitamin D, people forget that it's potentially toxic. Hydroxychloroquine, that's such a confused topic now, I'm not even going to try and talk about it. We need a lot more in the way of randomized controlled trials for seriously mentally ill people addressing their mortality. One of the things that we have done here is to use a sort of COVID benefit. You know, we used to talk about a peace dividend when the treaties were signed in Northern Ireland. What's the dividend here? So we have much quicker, more decisive, more efficient workarounds and case conferences. We have freed up staff to spend more time face-to-face with patients, even if that involves either a face mask or a video camera. But we are now auditing to see if actually we are delivering as many hours of face-to-face treatment as we thought. If that goes, then really everything goes. What about staff resilience? What about ourselves working day and night with these things? Well, interestingly, we very early on started by default to manage this. So the clinical director and the executive clinical director, myself and Dr. Wright, who's online, come in every day. But we are careful about distancing and minimizing face-to-face contact other than what is clinically important. The duty consultant, who is on for a week, comes in every day and attends to the essentials, the legal things like reviewing seclusions and so forth. Other consultants come in on the days when they do their ward round, on the days when they must, for instance, things like review boards, which are a huge part of our work, are now all gone to teleconferencing. So physical presence and overlap between key staff is minimized. And that's a pattern which I certainly heard Sandy describe, and I know from conversations with other colleagues that's happening in other sectors too. What will be our new normal? Well, one of the things which I think is striking is the extent to which we have rediscovered the commonalities that we have with other areas of medicine, and this shouldn't be surprising. Multidisciplinary working really came from oncology. Recovery as a concept really came from diabetes clinics, and the active management of length of stay came entirely from obstetrics. Epidemiology, randomized controlled trials, they didn't come from psychiatry, although psychiatry has always been a core epidemiological research subject. What we need to do to enhance our resilience and the resilience of our trainees, who are the ones most likely to struggle with all of this, is not just to train, but to educate. I am concerned that competency-based training is very much about ticking the right boxes in the minimum amount of time, and actually educating people is how you become resilient to the point where when something you're not trained to do comes out of left field, you have the abilities, the education to invent the right procedures, which is what we've been doing for the last 3 months. And most of all, I think we can do this by going back to a system where there were affordable postgraduate degrees and research and development, teaching and training virtuous cycle of excellence, which needs to be everywhere. That's something that Sandy and I have been writing about particularly. New hospital, new model of care. We have spent since the year 2000 developing the model of care for the new hospital. We now need to think about it all again. Interestingly, although this old 1850s building is universally decried, it has very wide corridors, high ceilings, lots of fresh air and light, because that's what the Victorians built in 1850. The new hospital, of course, has ensuite bathrooms and individual bedrooms, which are very, very spacious. So it will immediately be a huge assistance to minimizing transmission. But there are lots of other things we have to think about, and I hope we might talk about in these sessions to come. I hope I haven't gone on too long.
Thank you, Harry. That's perfect. I'll just invite Trina Wilkie to add to the discussion.
Thanks. Thank you for a very comprehensive and thought-provoking talk. I think for us here in Toronto, we're also working towards moving our program into some new buildings and thinking about our model of care. So we're in a similar space as we think about the impact of COVID, not just on our practice right now, but on how things are going to move forward. So I think from your talk, there were 2 points that I was reflecting on while you were talking. I think the first is that the pandemic has really reinforced the fact that our forensic system is a pathway. And that really when things are in a normal state or functioning normally, that there's a lot of movement. People moving from secure to less secure to the community, between jails and courts. And at this point, at least for us in March, there was a period where everything came to a halt. And limitations on passes, lack of movement. And I think initially that was met with a lot of acceptance. I think increasingly we're starting to see some boredom and frustration set in. But I think as we look about moving forward in a safe manner, to me, I'm reflecting on this idea of pathways as a marker of progress. And so if we're moving, I mean, we often use language like moving forward or creating momentum. And if we're moving into a phase where there is less physical movement, or at least it's happening at a slower pace, I mean, are there other ways or opportunities to consider marking therapeutic progress, both for the patients and also for the teams? I think this dovetails a little bit into what you were talking about looking at refocusing on hard outcomes. And one of those outcomes may be around how we measure progress when there's a state of less physical movement. Wonder what your thoughts are about that.
Well, during this time, patients have moved from acute to medium and onwards, while we've had minimal admissions and minimal discharges, almost in fact no discharges. So it's much more difficult to accomplish while you're not able to admit and discharge. I do think that patients being able to see real movement is such an important part of hope and motivation. You know, the best parts of recovery. Those are elements of a model of care which are so structural and integral that I would struggle to see alternatives. One of the things we do sometimes is talk about alternative models, one of which is the, I call it sort of the sponge model, where every ward admits and discharges. Now, I can see how you might argue that there's a COVID advantage. There are transmission disadvantages because you have admissions coming into every ward, and therefore you're more likely to have more problems across your entire hospital. On balance, the stratified pathway moving from admission, high support, high dependency, to medium, to pre-discharge, probably is a safe way of operating. But that's a good idea. We need to test. We need to know.
I think the other thing, I mean, it is a really interesting moment where telemedicine or virtual care has become very widespread and people are really appreciating, I think, in some way the benefits. But of course, this is not new technology. I mean, many people have aggressively been ignoring telemedicine for a long time or actively resisting it due to the things you were talking about, concerns about privacy or how it impacts on risk assessment. And I do wonder whether this is whether you think this is a bit of a turning point, not just for telemedicine, but other technologies in forensic psychiatry, whether we will sort of be more amenable to trials of things that people have been talking about, the use of apps, co-creation of our electronic medical records, the use of databases, these sorts of things, given the fact that many of us have now had experience with the use of virtual care. I mean, over time, we will see what the real impact has been. But whether you see, as you look at your model of care for the new hospital or going forward, whether you think this is a bit of a turning point for the use of technology.
Well, one of the things we're doing is designing an entire electronic clinical management system, which goes beyond electronic health records, visiting. So I do think that will benefit us enormously, but I'd be very fundamental about this. We look after the most severely ill people, who also happen to be the most dangerous. But on the whole, the pathway into long-term high support, high care is in effect a forensic pathway. Excluding patients who are detained and incapacitous from the research that will help to ameliorate their condition is wrong. It's a balanced argument. Of course, exposing people to risk without consent would be wrong, but at the same time, excluding them from randomized controlled trials where there is little or no risk is wrong. I now welcome a long debate about that, and I know if there were bioethicists on this call, they'd be jumping up and down. But I think it's important to take a polarized side in that debate. Why is mortality, standardized mortality, getting worse in every country where it's measured compared to oncology, respiratory, cardiology, where it's getting better? We're not doing RCTs, that's why.
And yeah, just the last point I'd highlight from your talk, which I thought was interesting, is about the remedicalization of practice. So I think Sandy's said in the chat as well that on our units, there's a hospitalist attached to every unit. And I think the collaboration between the hospitalists, the psychiatrists, and the interdisciplinary team has really been key to the functioning of both the isolation unit, but really all of the units. And I think that sort of collaboration going forward will be really important for all of us.
One of the challenges for us I completely agree with you about that. As a freestanding psychiatric hospital, forensic or otherwise, we're disadvantaged in that respect. And we are making efforts to bring what we call physicians, you would say hospitalist, in. So we're going to, for instance, have a metabolic clinic and other clinics where the specialists relevant to the physical aspects of care will be coming in every week. Something that we currently have general practitioners who are here 2 or 3 times a week. We need to keep building on that.
Thanks, Samita. I don't know if there's questions or comments from others.
I think the last comment, Harry, speaks to Aidan's question that he had posted earlier about the role of general practitioners in psychiatric care during the pandemic, and if you see that as being required in greater magnitude than it is currently.
Yep.
Yeah. I'm not seeing any new comments in the chat. Just give it a moment. Hi, Paul.
I didn't put a comment. I just thought I'd put up my hand. Old school. I'm just interested, you talked about telemedicine, and we at CAMH have tried it in different ways. I think the interesting part we've experienced is that some of the assumptions about doing virtual care in forensics didn't really hold up when everyone was kind of rapidly had to integrate it, such as, can we do risk management virtually? I think there was a lot of apprehension about that, and some of the evaluations from physicians has been, actually, it kind of works because there's so many other components. But it's also highlighted, I think, a lot of challenges with virtual care that maybe we didn't consider. I think for our outpatients, to be curious, one of them is around equity, that a lot of our outpatients, we can do virtual care, the hospital can have all the technology, but it's only as good as, you know, the other party having a device, internet, a private space to use it. And so that's been challenging. We've had some weird scenarios where patients actually have to come on site to the hospital to do virtual care with the physician who's also on site as part of the pandemic part. And some that have their own personal devices, we've been able to do distantly or remotely, which has been very, I think some patients appreciate because they're traveling very far in a big city. But I'm just curious how virtual care has looked on the outpatient side of things for you.
Well, really opinions are divided. I've, for example, personal experience, I've seen someone in Cork, which is the second city in Ireland. It's, rather than tell you how far away it is, I'll tell you it's about 3.5 hours away. So normally that assessment—
That's normal Toronto traffic commuting.
Yeah, probably. That would have been a full day's, you know, so essentially I'd have spent an entire day getting there, doing my assessment, talking to my colleagues and coming back. It took me 2 hours. And that enabled me to do all that I would have done otherwise. So, yeah, no way, we're not going back. Having said that, some of my colleagues quite reasonably feel that it's not the micro nuances of a mental state aren't the same. I understand that. I visit in a brand new children's detention center where the architecture is very new, and the screened visits there, originally to prevent drugs coming in, are just wonderful. You know, you really don't know that you're having a screened visit. The way it's designed, it works really well, and it's all the advantages of a face-to-face interview, but with a very effective screen. I think that will probably become the new norm, certainly in the prisons.
Yeah, I think it's interesting, you know, for us too, the IT has been really helpful. We have a new software, we're using WebEx, it's kind of like Zoom, but it's realizing how it is in context of a lot of other factors to make it work well. And sometimes it's the hardware and other aspects. Sometimes it's just having administrative staff on that side, knowing to operate it and set it up for you, even if you're highly skilled. And I think it could be really easy, but there is a very steep learning curve, and it is extra burden and responsibilities, I think, for staff to implement virtual care that sometimes we don't see even as physicians. And
Thanks.
So it's not that it doesn't work, it's just there's a lot of components to it, I think we're finding out.
Thank you. I see Gary.
Yeah.
So Harry, I have a question for you. It's slightly provocative, but I think it's a really important one. And I reflect on the pictures of the people that have been taking up some of the airplay on this, including myself. There was a headline in one of our Toronto newspapers a week or two ago, which is among other things, which was, it said you can have old people or you can have an economy, but you can't have both. So one of the struggles that we've got is that we've got a number of older physicians. As you know, the average age of physicians or psychiatrists, pushes on the cusp of where the risk is. And we've had people working at home, but what are we doing, and what are you doing or thinking about bringing back to work, and how do you bring back to work the over 60s or the people with medical conditions? And I think it's a struggle for me because we've got people off work, who've been given medical leaves or time away from work, working from home. But at some particular point, we're going to have to do that. And there are other people who are going to be red circled because of multiple medical conditions. So we've got the potential, we've got stigma, justice involved people are stigmatized, as we've spoken, and everybody knows. But there will be, and there is, not only the stigma, but also the reintegration or of us back into the workplace, especially when there's COVID in the workplace. What have you guys done with that? Has that been an issue for you?
Harry, just before you answer that question, I'm just going to do a time check. We have about 5 minutes left, and we have a couple of more questions after you're done with Gary's question.
I think that's such a huge question. We should come back to it in one of these series. I think we probably all have experience both of patients and of colleagues who are cocooning due to immunosuppression of one sort or another. I mean, if there were wheelchair users, we'd be fine. We now need to innovate.
We have a question arising about how do we support those who are not allowed to access the internet? After this question, I think I'll just invite Harry and Sandy to give their final remarks before we bring this webinar to a close.
Can I offer that one to Sandy?
It's been a significant issue with some of our sexual behaviors clinic clients with history of child pornography and inappropriate internet use who can't access, for legal reasons, for probation oversight reasons, the internet. So there will be groups like that who get thrown up by it. There are also huge issues for people who are deaf and for whom masks and other ways of communication are problematic. So I think we will find the more unwell, the people who have difficulty engaging with remote platforms, people with delusions about it, the people who are not allowed on because of legal issues. There will be glitches with quite a number of people. I suspect remote work is going to work well for 75%, and then we're going to have specific things for each of those. I'm not quite sure exactly how that will come about, but we're trying to address some of those and trying to arrange with probation for some of the people who are not allowed internet access to be able to still access virtual assessments with SPC therapists.
Okay, Harry and Kennedy, we'd love to hear your final thoughts before we wrap this up.
Well, a sort of meta thought is how important it is to communicate in this way. If there was one key thing that I feel we all got right here during the last 3 months, it was the system of having a daily huddle handover, which is then cascaded to everybody almost instantaneously. A daily phone in amongst the senior management team immediately after that to review where we were going as we improvised and struggled to keep up with anything from where to find PPE through to how to generate cohorting space. The national phone in for all the clinical directors. The extent to which lay managers and others simply took a back seat and left us to get on with it and facilitated us. That was part of the remedicalization. That was the really interesting part. So communication amongst this peer group, I think, is terribly important. We've probably got half the active forensic psychiatrists in the world on the line at the moment. There's 57 on, and several of those are cameras in large rooms. So I do think when we can't all meet at the International Association of Forensic Mental Health Services or forensic faculty, we have to do this. And we're still in a phase with this where working through the questions that have come up over a series of these, 3 or 4 more of these at fortnightly intervals will be just a huge help. I'm fascinated to hear what people are doing.
Thank you. Sandy?
Just to echo Harry's comments, it's been lovely to join up with people and to kick this off. Thank you for everybody for their attendance and comments. Keep them coming, and do email us with other thoughts. We'll be here again in 2 weeks, and we'll send out to you a tentative program. But if you're interested in contributing and adding further things or have advice to us as to how to improve this, please send them through to us. And let's keep the conversation going. Lovely to see everybody in this way.
Thank you. So that wraps things up for our first Forensic Psychiatry CPD webinar. I'd like to thank our speakers and especially all of you for coming out today and joining in on our discussions. If you have any further comments, questions, or topic ideas that you would like discussed in future webinars, please send them our way, and don't hesitate to reach out to us. Have a great day, everyone.
Samita, thank you for chairing, and thank you to the discussants. Cheers. Sandy, I might give you a shout later.
You too.